Hello all and welcome to this online presentation on critically appraising studies about prognosis. So in this presentation we'll briefly discuss the different types of evidence or the evidence base around studies around prognosis. We'll discuss the representing prognostic factors in terms of Kaplan-Meier curves and survival curves. And finally, we'll introduce the notion of hazard ratios as opposed to relative risk in studies around prognosis. So what is prognosis? Fairly simple definition. It's just the prediction of the future course of the disease following its onset. So it's useful from a patient perspective because A, they want to know about the course of the disease. So what am I faced with and what are the challenges? But it's also useful for making specific decisions around treatment options. So for example, if we're looking at a patient who's been diagnosed with localized prostate cancer, he will have a variety of treatment options, whether it be radical prostatectomy, watchful waiting, radiotherapy, active surveillance, etc., as opposed to someone who's been diagnosed with a much more aggressive form of prostate cancer, in which case some of those treatment options may not be relevant at all. So what type of study design or study designs are available for prognosis? Once again, we've got both interventional and observational studies. So surprise, surprise, randomized controlled trials are at the top of our level of evidence, but we can also use case control studies and cohort studies. And they both have their benefits and limitations, which we'll discuss over the next few slides. So as we've seen with many of the other study types, RCTs provide the best level of evidence because they provide the opportunity to overcome for different and specific biases in selection bias, performance, attrition and detection bias. RCTs are also particularly useful because they both provide information about the prognosis about intervention as well as control, and in particular when the control group is literally no or usual care or no specific intervention, it can actually provide us with useful information on the natural history of a disease. So for example, and apologies for once again using the prostate example, if we had an RCT in which we randomise patients to either have a radical prostatectomy or have what they call active surveillance, which is literally not doing anything, just monitoring the PSA levels, our control group would provide a great opportunity to assess the natural history of the disease in this case. However, our RCTs also have severe limitations. As with most RCTs, they often have a relatively short follow-up time frame. So when we're looking at studies around prognosis, we're not just interested in 6-month or 12-month outcome data. We're interested in more long-term, 5-year, 10-year, 15-year survival aspects. So you don't really get a whole lot of RCTs that run for that 5-10 year period. As we know by now, any participant who's selected for an RCT has to abide by a strict inclusion criteria. So whether or not those particular participants are representative of the general population is also a question mark. And then again we have, of course, the issue of placebo and placebo effects, as well as the Hawthorne effect, in that any participant who participates in a trial their outcomes will automatically change just because they're a participant in the trial. So whether that be the placebo effect or whether that be the Hawthorne effect, we'll see some changes in their outcomes as a result of actually just being in the trial itself. So when we're looking at studies around prognosis, we're generally looking at studies that are observational. So whether they be case control or cohort studies. To be honest, the majority of them will be cohort. So whether they're your traditional cohort studies, in the sense that we've both got an exposed and a non-exposed group, or whether they are what we call an inception cohort, in which we're just looking at one arm of the cohort study. That is, we're just looking at the exposed group or the unexposed group. Similarly for case control studies, same sort of opportunity arises. The only, I guess, major limitation with our case control studies is that we have the limitation around response and recall bias. So that can play a huge effect, particularly when we're looking at studies around prognosis that may be 5 or 10 years in duration. Okay, so when looking at studies that are observational, we're looking at or we're looking to examine risk factors for a particular disease. So once again, cohort studies tend to be the main type of study in which we use when we're looking at studies around prognosis. Generally speaking, because we've got the two groups, the exposed and the not exposed group, that have been exposed, or in this case not exposed to the risk factors, and they're generally examined for a long period of time. So their potential for selection bias, attrition bias and detection bias is minimalised. The issue of performance bias may be an issue that can be overcome down the track through various adjustment in the analysis. So over the next few slides, we'll just talk briefly about the three I guess main types of bias associated with studies around prognosis. So the first bias is assembly of patients, and really I mean in this case it's called sampling bias when we're referring to studies around prognosis, but you can essentially view it as selection bias. So who are we assembling? How have they been assembled? Where have they been recruited from? Can we then generalise the results from that particular group of patients to the wider population? Follow-up, again, just refers to attrition bias. So particularly in studies of prognosis, we tend to have quite a lot of loss to follow-up, just because we're looking at studies for a longer period of time. So as mentioned previously, typically we're looking at 5-year survival times for studies around prognosis. So actually trying to follow someone up for a five-year period can be quite difficult, and you may come across issues such as non-response bias. That is, people just don't want to respond to your online survey, your questionnaire, your telephone call, the clinical appointment, whatnot. So in assessing these participants in terms of loss to follow-up, not only do we identify why they have or have not continued to participate in the trial, we also want to examine, are there any specific characteristics that represent these participants that have chosen not to respond for this particular study, and has that some sort of effect on the overall prognosis within this cohort or sub-cohort of participants. And finally, we have outcome measurement, and you can think of this again similar to detection bias. So in terms of the endpoints, studies around prognosis want to have both patient and clinician relevant endpoints. So we want to, any instrument that we're using, we want to ensure that it has been validated. So there's the obvious death or survival. It's fairly easy to measure that. We don't need a psychometrically validated tool, but outcomes such as functional status, quality of life, often require validated tools in order to assess these outcomes. Otherwise, they're really not that useful. And of course, finally, was there any blinding of the observer? So looking into that detection bias aspect of things, ensuring that our outcome assessors are blinded. So I mentioned earlier that sometimes, even if we have discrepancies within our population, when we're looking at studies around prognosis, we do have the option of adjusting for these factors and seeing what type of impact they may have on the overall prognosis. So if we identify within our cohort of participants that one particular group is older or has more comorbidities such as diabetes or hypertension than another group, we can do what we call a multivariate analysis and identify what, if any, impact those specific outcome measures have upon the final prognosis of the participants. So, for example, does being over 50 years of age and a diabetic increase or decrease the prognosis of a particular patient for a particular disease? So this is a table just to try and summarise the different biases associated with prognostic studies. So we've got the three biases: sampling, non-response and measurement bias. And realistically, you can just think of this as selection bias, follow-up or attrition bias and detection bias. And across the three particular biases, so if we look at sampling bias, just refers to how did the researchers assemble the patients, and ensuring that they're as similar as can be at baseline for those demographic characteristics. When we look at non-response bias, so attrition bias, we're referring to the follow-up of patients, and we're looking at reasons why they dropped out, looking at identifying are there any characteristics across the groups that did not respond, and whether or not we can predict anything from those measurements that we take. And then finally, measurement bias, which you can also refer to as detection bias, and that is focusing on the evaluation of outcomes. And once again, we want to ensure that the outcome that is being assessed by the outcome assessor is blinded, and that they are using a validated tool if it is appropriate. So the next couple of slides, I just wanted to refer to, differences between rates or relative risks and hazard ratios. So rates really simply convey simple little bits of information. They don't actually tell you how information changes or survival changes over time. So things like relative risk, odds ratios, number needed to treat, relative risk reduction, etc., although they're great, they only provide you information about one endpoint in time. They don't provide you information with how those outcomes change over time. Conversely, survival curves and Kaplan-Meier curves incorporate time to provide us with that additional information. So Kaplan-Meier curves, which hopefully everyone's seen and we'll illustrate in the next slide, are distinct by their stepwise appearance. And the stepwise appearance occurs because that is when we measure the event rate at that specific point in time. And I guess it's best to illustrate that with the next slide. So here we have a Kaplan-Meier curve. So on this axis here, we've got 0 to 1. So in this case, we're looking at the proportion of cases. So 0 being 0 cases, 0.5 being 50% of cases, and 1 being 100% of cases. So in this particular example, we've got our placebo group with this particular line, and the dotted line represents treatment group. So commonly, these type of curves, Kaplan-Meier curves and survival curves, are reporting what we call a bad outcome. So you can think of something like mortality as a bad outcome. In this case, we're looking at a beneficial outcome. So we're looking at time to symptom resolution. So if we look at, for example, the placebo group, well, we can see at time point 0, both the placebo and treatment groups are the same. So 100% of patients are at this point, and none have had a resolution of their symptoms. When both groups are measured at this first time point, we can see that there's quite a big drop in terms of the placebo group. So we've had quite a number of participants at whatever this point here is, have a resolution of their symptoms. But if we look at this particular group here, being the treatment group, we can see that many more at this particular time point have had a resolution to their symptoms. The reason we can identify that is by drawing an imaginary line across this axis here. So at time point 1, it may be that only 5% of patients in the placebo group have had a resolution to their symptoms, as opposed to the treatment group, in which we might be able to hypothesize that it looks like 20-odd% of participants have had a resolution to their symptoms. So if we follow the two groups, and if we follow the treatment group, at this time point, everyone in the treatment group has resolved their symptoms, whereas if we compare it to our placebo group, at the exact same time point, if we sort of go across this area, we could estimate that only 75% of people in the placebo group have had a resolution to their symptoms. So here's another example using survival curves. So survival curve A, fairly simple here. Everyone seems to remain fairly much at that 100% or thereabouts level across the follow-up period, so follow-up being 3, 6, 9 and 12 months. So you could easily identify that if you're in this cohort, the percentage survival is fairly high after 12 months, so there is a good prognosis. Group B, we can identify in the early versus later aspect of the prognosis. Early prognosis is good, and then we start to see a slower increase in mortality. I should say poor prognosis in the first instance, because 50% of patients have not survived the 3-month period, but over the next 9 months we still have about a quarter of patients surviving. This is opposite to this graph in Group C, where we seem to have a good early prognosis for at least for the first 3 months and beyond, and then after that we see a dramatic worsening in terms of survival. So Group A, good prognosis all along. Group B, poor early prognosis, but then a fairly decent prognosis long term. Group C, early prognosis is great, although by midpoint that prognosis decreases. And Group D here, we've just got a steady linear prognosis. So we've got a linear gradual decline in prognosis over time. The last aspect that we'll talk about is hazard ratios. So as I mentioned, hazard ratios, you can think of them as similar to relative risk. The only difference is that hazard ratios take into account time. Much like relative risk, if you have a hazard ratio of 1, it suggests no benefit. Anything less than 1 suggests a benefit towards the intervention. Anything above 1 suggests a benefit towards the control or the non-intervention or non-exposed group. So to provide you with a bit of background in terms of how you calculate hazard ratios take into account, as mentioned, the impact of time in a particular disease. So, for example, if we were just looking at one group, so let's say we're looking at the intervention group in which we had 1,000 patients. Let's say we assessed them at the end of the first month, in which 10 out of the 1,000 have died. The hazard rate, so the rate for that intervention group, would be 0.1. And then we do the same for our control, in which we get our hazard ratio. If we were to then follow up the same cohort of patients for the second month, we'd have to take into account that we've already lost the 10 from the first month. So in the second month, let's say 15 patients died. This way, we would have to calculate 15 divided by 990 to get our hazard rate. So as mentioned, hazard ratios, and in this case, if we're just looking at one group, that being the intervention group, the hazard rate takes into account the changing numbers over time. So the final slide, we'll just run through a graphical example, hopefully, of this. So a hypothetical scenario in which we've got 400 participants, 200 to the intervention, 200 to the control group. Let's say after the first time period, we've got 5 out of the intervention and 10 out of the control group pass away. So our hazard ratio would be 5 or 50% in terms of the hazard ratio. Moving on to the second month, now we have 10 out of 195 in the in the intervention group, and 20 out of 190 in the control group. Our hazard ratio is 0.48. So it tends to reflect the better prognosis in terms of being allocated to the intervention group. Again, if we go with our third time point, once again, we can calculate that. We can see a trend that our hazard ratio tends to move significantly more towards the intervention group, and demonstrating a significant benefit in terms of survival in this case, or overall prognosis for our intervention. Once again, thank you for your time, and if you have any questions, feel free to email me. Thank you.